Schauen wir mal, wer da kommt. So I think I will start now. We have a few participants so far. And while we're waiting for the others, I will give a kind introduction. Hello, everybody. It's my kind pleasure to welcome you to Young ESPGHAN Webinar Series. Today, we're talking about ethical dilemmas in pediatric liver transplants. And we're welcoming Norman Junge and Steffen Hartleif. And I'm Benno Kohlmeier moderating this session. I'll give you a short overview about Young ESPGHAN. This is a Young ESPGHAN webinar, and I'm part of the Young ESPGHAN committee, and the mission of the committee is to promote high-quality research and training, organize activities for Young ESPGHAN members, and represent the interests of Young ESPGHAN members within the council and the society. We're having a lot of Young ESPGHAN educational events, for example, the mentorship program. This is a forum for young trainee members to receive support from experienced ESPGHAN members. This is ongoing since 3 years, and we have very good results. Each year we start a new term, and we have 10 mentors and 10 mentees. They are pairing up. We're starting with an online workshop in April, and then there is a face-to-face meeting at the annual ESPGHAN meeting, and further on there are meetings where you meet your mentor and mentee. We're also very active on the annual meeting. On Wednesday, there is the Young ESPGHAN Day, where we have a program from 1 p.m. to 6 p.m. We will have, of course, about research, systematic reviews, how to do meta-analysis, how to do peer reviews. And this year, very new, first time, we will also have a session on Saturday. It's the Saturday session from 1 p.m. to 2 p.m. 40. Where we will talk about clinical cases, and it's the chance for you to submit your clinical case and discuss it with an expert, no matter in what field of pediatric hepatology, gastroenterology, or nutrition. Just send your case to office@espghan.org, and we might select the best ones, which can be discussed together in a team. Another thing we'll do on the annual meeting is also meet the president. So this is a very easy chance to have your questions directly asked to our president, who is currently Uli Baumann. And I think this is just a very, very nice informal meeting. So who are we? Currently, our chair from the Young ESPGHAN is Anne-Marie Klima, but we also have further members like Vangelis, Petra, Anna, Pina, Francesca, Mariona, Jose, Giovanna, Harvin, and me. So the only questions which is left now, are you a member yet? If not, then go and join us. There are a lot of benefits if you become a trainee members. You get a subscription to our journal, to the JPGN. You get a subscription to the newsletter, but there are a lot of other nice benefits, like reduced registration fee for the annual meeting, or you can also attend members dinner or access the Young ESPGHAN launch. You can access ESPGHAN research grants and awards, and you can also become, if you apply, you can become part of the Young ESPGHAN committee. So how to become a member. There is an application form on the website which can easily be accessed. You only need a CV and a letter of support from a full member not serving in the council. You can find our latest news also on social media, for example, on X or Instagram. And talking about the Young ESPGHAN webinars, which is one of our core projects, we will also have further webinars this year. Another upcoming webinar will be in April about machine learning and AI. But we'll also have a webinar in June about unraveling the gut-brain connection, in July about life-saving nutrition, the role of enteral feeding in pediatric intestinal failure, and another one in August about nutritional management in eosinophilic GI disorders. So we're almost about to start. It's my real pleasure to introduce Norman Junge. He's a pediatric hepatologist working at the University Clinic of Hanover, and he is part of the ESPGHAN Hepatology Committee. And I'm introducing Steffen Hartleif. He's also a consultant pediatric hepatologist working at the University Clinic in Tübingen, and he is the chair of the Craft Injury Group. So very welcome, and I will give the screen to Steffen.
Yes, thank you very much, Benno. So welcome to this webinar. Actually, this is for us a very, very important topic in clinical life. Ethical aspects in pediatric liver transplantation are many times very important topics. However, I think it's a very interactive topic and we should really discuss today. So I think webinar is a good chance to meet online. However, I think discussion is very important. That's why we thought to set up a Menti site. So please use the QR code and go directly to the interactivity, because I like to hear to see your thoughts and also your opinion. How would you decide in these critical cases? And because I think it's very important to exchange on these facts and really to think about our thinking, about the way we decided. And we are both very curious to hear about your opinion in these cases. So the agenda is, first, sorry, we have nothing to disclose, and now I can just jump to the agenda, to the overview. So I will give you a short introduction about general aspects in pediatric liver transplantation and why ethics are so important in pediatric liver transplantation. And then we will have altogether 5 cases, 5 cases with different disease. And so please use the QR code to go to the Menti app, and then you can add your comments and finally also send us your opinion, your decision about the specific case. So I think not all of you work in pediatric liver transplant centers. So here's some short key facts. As you all know, liver transplantation is the only curative treatment for many chronic and also acute liver diseases. It's really the state-of-the-art therapy. We can deliver very good outcome for most of the children. And in 2022, this is the latest data from the ELTR registry, 585 children were transplanted in Europe. However, the number of transplants is not increasing over the time, it's more decreasing. Living donation, which is also a possibility to perform liver transplantation, is the same number over the years, but transplantation via a post-mortem donation was less in the last years. And you're probably also aware about the common indications for pediatric liver transplantation. So in childhood, it's mainly biliary atresia, where the children are transplanted, but also metabolic liver disease, acute liver failure, and also genetic and autoimmune liver disease account for liver transplantation in childhood. And so far, liver transplantation is really a success. So we have a 1-year survival over 90%, 5-year survival over 80%. And we see that patients who are stable in the first year have a very good outcome long term. So the half-life time of a transplanted liver in childhood is about 30 to 40 years. So I think it's really a success, and we can offer a good outcome for the children and the families. And we're facing a problem, a global problem, global organ shortage. So there are a lot of children worldwide listed for liver transplantation, but only a fraction of them will receive an organ donated from a post-mortal donor. So liver transplantation indeed is for children a very good option. Why is ethics so critical in pediatric liver transplantation? And so the first point I just mentioned is the scarcity of organs. So not every patient will receive an organ. Not every patient who needs an organ will receive an organ. So we have decided in some cases. And the difficulty is that we are mostly talking to parents, and parents are driving the decisions. And in some ways, it can be very different to the child's best interest. So we have to keep that in mind. Also, we have to keep in mind to think about the risk of the donor. Can we really do a living donor liver transplantation if the parent is under risk, if the outcome of the child who's receiving the organ is unclear? So we have to think about that. And another point, important point, is non-adherence. Non-adherence of children, of young people, and also non-adherence of the parents. So in adult liver transplantation, non-adherence would be a contraindication for liver transplantation. I think in children we will discuss, it really depends. And if we have these resource problems, we're always talking on another level. Should children have the priority, and what's about the prognosis of the disease? Shall we take that into account if there's a systemic disease, for example, which can recur after liver transplantation? So these are the things we have to discuss. And difficult decisions we will have in many cases, and we have to do somehow triage and to think about our responsibility, and to think how can we best help the children. And as I mentioned earlier, systemic metabolic diseases are difficult in a lot of cases, because, for example, mitochondrial disease, it can be different courses with good neurological outcome. In that case, we can discuss about liver transplantation, and also mitochondrial disease with worse neurological outcomes. So liver transplantation would be contraindicated. And we have children who might not be able to care for themselves with impaired neurocognitive stages. So this is also a point which might need discussion about the decision for transplantation. And also retransplantation is a topic, retransplantation because of organ loss after non-adherence. And so should a patient receive more than one organ for his disease, or how is it with the responsibility in these cases? And also we have some cases with acute liver failure due to intoxication with drugs, and also intoxication to suicidal intent. So this is a point we have to discuss. What is the best situation for our patients? And is living donation an alternative in cases in what we say post-mortal donation, liver transplantation from a post-mortal donor is not the best option? Is living liver transplantation in these cases a better option? Not a question we have to discuss. So a lot of ethical considerations, Norman.
Yeah, if we try to put all these different aspects in a kind of a picture with a scale, it could, like what you see now on the one side, on the pro side, there's a benefit for the patient, of course, due to the liver transplant, the outcome, the life expectancy with and without liver transplant. On the other side, you have the patient-specific contras like non-adherence, like we heard about, contraindications, maybe a very severe systemic disease, or also the unclear progress of this disease after liver transplant. And then on top on this, very on the top, the organ shortage comes up, and this always weights the scale a little bit to the contra side for liver transplantation, which is not a good situation. And in an ideal world, it would look like the middle scale, where we really have just the focus, the patient aspects and no other aspects. And this is really difficult to handle because, like Steffen mentioned, we also have the responsibility for the whole amount of patients who are waiting for a liver transplantation. And if we say, okay, maybe we can solve this problem with living donation, would be quite easy. No, it's not that easy. First, not always there's a living donor. And second, again, this adds something to the scale, the risk for the living donor, which also counts more on the contra side, of course. So it's always difficult to handle the different aspects.
Well, so I like to start with the first case. So we really like to discuss cases with you. And the first case is on a girl with Coach syndrome. Coach syndrome is an acronym of cerebellar vermis aplasia, oligophrenia, congenital ataxia, coloboma, and hepatic fibrosis. So these are children with cognitive impairment, some worse, some less, and also liver disease, and in some cases also with kidney disease. And this girl was presented to our center some years before with Junge syndrome and also liver fibrosis and progressive portal hypertension. And she presented acutely with variceal bleeding that could be handled with band ligation. And then she was quite stable with compensated liver function, moderate jaundice. However, we did know that liver disease would proceed, and the question now was, should we talk about liver transplantation? You have to know that the patient was mentally disabled. She was not able to speak. She could walk with help. She was very anxious in every clinical situation and had panic on any intervention. Even drawing blood was horrible for all of us. So she was really in stress when she was in the hospital. And the parents were not able to speak any German or English. They were in Germany for more than 10 years before, but were not able to speak any German, and it was very difficult to communicate. There was a brother of the girl. He was able to speak German very well, but the family did not follow all of our instructions. They did not come to the regular appointments. They were not able to take the drugs, the vitamins. So there were a lot of difficulties in the management of this girl. And so now we have this situation, liver disease, progressive liver disease, portal hypertension with bleeding. And we were thinking, shall we list the girl for liver transplantation and put her on the waiting list? And I really like to hear or see your thinkings. What do you think is important in this case? So please use the link, and then we can see your questions or your points you think would account for or against liver transplantation in this girl. Sorry. So now you should.
Yeah, it works now.
It works perfectly. So everybody who's online, please use the link. And write your ideas. Yeah. So one who wrote it in the comments, please just write a response so everybody can see it. So maybe I can I give 10 seconds more and then I can start with maybe to start commenting, or you can also comment, Norman, on the points we're seeing. So I think for most of you, the adherence is the main problem in this case, or your main concern in this case. And indeed, it was also our concern. I think, don't know how do you handle these, Norman. I think for us, adherence is a very important point. Not as adherence of the child, adherence of the whole family.
Absolutely, I agree. This is absolutely important. In this case, where the patient is really depending on the parental care even more.
That's also a point. There's no option putting the girl in another family. So that's why I think it's important to stay there. And then the benefit, somebody wrote that, is really in question. Yeah.
Steffen,
So
can I ask?
yeah,
Can I just ask, is the neurological prognosis of that girl? Maybe I didn't get it.
it will not. It
Is
should
there?
be. Yeah, the
Yeah.
prognosis is that she will stay stable. It will not become worse. She will become stable. So also think was, oh, how is the risk about hepatic encephalopathy? Yeah, can hepatic encephalopathy make the cognitive situation worse? So normally the patients stay quite stable and are not decreasing over time or getting worse over time. It's a stable situation. Liver disease and kidney disease get worse over time, but neurological development, in my view, in these cases was quite stable. Good, so thank you. Now I have a look for the other points. Yeah, I think that's what we, and I think the lack of benefits is also a point we discussed, because she's quite stable and it's portal hypertension. Are there other options? So maybe we can, everyone who did not write anything has now the chance, just very easy to say what to do.
And it's anonymous.
Yes, it is. It is, and I think
Don't be afraid.
the important point, you will get to this later, is there is no right or wrong. Right? Yes, it is. It really depends on the individual case and situation. I saw 30 people online at least, so at least we need more than 10 responses.
I don't know if Menti is not working for everybody. Yeah, that's maybe good. You go back to the QR code, and also you can type in the address. If your phone does not support QR code, you can just go on www.menti.com and then either with that link, or Steffen also showed a number in the slide before. Then you can also enter a number, because maybe not everybody is online since we only have 10 votes.
Or we go with the next case, and then we go. I look Some people did vote via Zoom. Thank you for that. And this seems to be stuck, someone wrote. Hopefully it's now, it's in case anyone wants to click. Someone wrote, but it did stuck in the past, but should work now because I moved forward. Thank you for that comment. So maybe I can have a look whether the vote changed again. Okay, so I think we continue and I will present you what we did. So you always see what we did. We did not list the patient for LT. I think one point was that she was quite stable and portal hypertension was the main point, but we were really worried about the family situation and the non-adherence, and we thought, how can we best help the patient? And we put or we used tips, a transjugular intrahepatic portosystemic shunt to decrease the portal hypertension. And afterwards, actually, she was quite stable. Now, 7 years later, I just checked, she's still in care of the adult unit. Liver function and cholestasis and liver synthesis also got really worse. She's in a bad situation, but she's still at home. She's still stable. And they discussed again about liver transplantation. And there were another situations where they realized the family is not compliant and it's not possible to perform a liver transplantation because the family would not be able to care for the girl afterwards. So they also decided not to transplant. But Joubert syndrome is not Joubert syndrome, so we continue with another case from Norman.
Okay, so now we're at case 2, and it's was really funny when we both thought about how to put up this webinar, and we both came around with Joubert syndrome case, completely independent from each other. So this is case 2. Here I have a picture from the CMRI of this patient where you can see just it's not liver nothing with the liver, but you can see the very typical MOLA2 sign of these patients, what you can see in the MRI due to the aplasia of the dense vermis. It's really nice to see. So, but coming back to the liver part of the patient, so like you already have heard from Steffen about the disease, the patients are mentally disabled. He could not speak or walk. He was communicating by sounds and facial expressions and had a severe liver fibrosis. The main problem was portal hypertension, bleeding, ascites, and so on. So we decided, like Steffen and his team did, to do a TIPS. But unfortunately, after this, everything got worse. Really big problems, fatigue, weight loss, increasing cholestasis, really increasing cholestasis, also decreasing kidney function, maybe hepatorenal syndrome. So at the end, we decided in this patients, and I tell you already, for a combined kidney liver transplantation, and you can see the pictures here at our transition seminar after the transplant. One of the big differences between the two cases for sure is, and what we already have worked out in the discussion before, the compliance and the care from the parents for this children, because they have been very, very helpful and very good dealing with him. So yeah, this was our decision in this case, but of course, and this is what we want to do, to discuss it with you. What do you think? Well, is it right to do it this way? Of course, it will not heal the syndrome themselves.
So we see same disease, but maybe different situation. So again, while you're thinking about this case, maybe you have questions you can ask as well. So we can move to Mentimeter. Hopefully it's working on your cell phone. You can also just write straightforward if you think it's straightforward.
Okay.
That was myself actually, but or there's one comment. No, there's no comment. Ah, okay.
Mm-hmm. Mm-hmm. So maybe I can already comment on this while we are waiting for further comments. This was a deceased donation, living donation, at least a left lateral donation would have not been able because the age or the weight of the patient. And this is also, of course, a very important aspect. So we have two problems in these two cases. We have the one problem, how or are we allowed to decide which patient's impairment is worse to be transplanted and which not? And it's almost similar in both cases here. And the other one is the parental care, and especially in these patients where they cannot care for themselves, and it's not the fault of the patient to have these parents, you know. I mean, it's very difficult. In this case, the patient is still in a very good status at the moment, but still the parents are looking for him. Yeah, they are very much looking for him.
I think that's also a point which is difficult in children with neurological disease who have impaired neurological function, impaired neurocognitive function, and who will need someone for the whole life to care for him or her. I think that's the situation which we might have, and then we have to discuss whether to do a transplant in these cases. I know from other countries that they decide if the patient is not able to look after himself and is severe disabled and impaired, then it might be difficult to perform transplantation. What do you think about this, Norman?
It's a really tricky question. I mean, we cannot say. I would say we really give him life quality and more lifetime. He's, like you have seen on the pictures, he has so much fun in his life. He really enjoys it, and of course he's disabled, but does this give us a right to say he's not in the right to get a medical care which would help, and what it does indeed, it's difficult.
Yeah,
I would say we are not in the right, but yeah.
Yeah.
It's again, if you then think back on other childs waiting for a liver transplant in a very severe status, and maybe with the chance of taking care for themselves or being in a what we say normal life, having a job and having kids later on in her life. But it's not up to us to judge this.
Right. I agree. I think quality of life is the most important point. And that in our case, it was that we were worried about the quality of life of the girl, and maybe her quality would be even worse because of all the interventions would be needed, and she didn't understand at all what we are doing in the hospital. So she was really frightened. Yeah.
And I don't understand. I don't know why was this comment just appeared and disappeared very short time. But of course, this is right. It's not only giving him a liver; it's also to take care of the liver. And this was, in this case, not a problem. This was given by the very, very motivated and very helpful and very, yeah, loving parents. Yeah. Okay. So
again, the question regarding neurological outcome.
Like you mentioned, it is stable. He will not improve due to liver transplant, but he will also not it will not get worse, which it could with hepatic encephalopathy. But yeah, in this after transplant, it was quite stable. Yeah.
There's a helicopter coming to the hospital, so I have to close the window. Okay, so we go on, and just how would you decide? Just quickly
Give us a
press
quick
yes or no.
impression. Like Steffen mentioned earlier, it's not really a wrong or right what we are doing here, just to get an impression. Okay.
Okay, I think we continue with the next case. Thank you so much.
So it seems like everyone
Please go for a liver transplant.
or most of the people, at least the people who voted. I think the next slide would be the scale again, maybe or not. Yeah, so this is obviously what we, what our decision was, or how we saw the things. Yeah. With the benefit and the outcome for the patient bigger than the cons. Okay, so the next case.
Okay, and there are some questions, some comment on Menti and improvement of Menti, but we will do that. Okay, so next case is another case from my institution. No, it's your case. Sorry.
Yeah, this is I would say yeah, more difficult, or I mean they are all difficult. It's a patient with biliary atresia, the main indication, or the most frequent indication for liver transplant in children, transplanted in a very early age of years, so you can already guess that it was a Casey failure. And the liver transplant, or the patient was, or the parent of the patient was already evaluated for a living donation liver transplant, because the situation, the clinical situation was so worse that we were very afraid of mortality on waiting list. Could you go further, Steffen, please? The next. Yeah, okay. So, but by luck, or maybe not, we cannot say, but really in the night before the planned living donation, there was an organ offer for him, and he was liver transplanted with a deceased donor organ, and it was a very, very, very difficult surgery with massive adhesions and massive blood loss and transfusion, and it was very difficult, really. Okay, next one. And it stopped not at this point. It went further on with many problems, unclear problems with the graft, not really a clear primary non-function, but really a significant portal hypertension, gastrointestinal bleeding, intra-abdominal compartment syndrome, not in portal stenosis, which we could have addressed. It was at least the more tissue aspect with the portal hypertension. Due to this, a really immense gut edema, a paralytic ileus. The portal pressure was like 40 millimeter, and the kidney function decreased, and he developed respiratory insufficiency. Later on, we have been told that other side of the organ, the right side, the right split, also performed very worse at a patient who gets this one. And now we have been at the point what to do. It was quite obvious that it's with this situation, with this organ, the patient will not survive. It was a really marginal clinical situation, and but also the expected survival for a real liver transplant in this patient was below 50. We all have the feeling or say, and to get a diseased donor organ was not really realistic. We could have tried, but it was not really in the classical criteria for relisting. We still have the father who was already evaluated for living donor liver transplant and also willing to do so. He was not an ideal donor, but acceptable. So again, it would have been not perfect living donation organ. So should we do a living donation with the expected survival rate below 50 of this patient, and with an organ which is not perfect and putting a risk on a father who is also father for other childs? Also, again, to put on this, the only person in a classical role situation earning the money for the family. So, yeah, I would be very happy to see your ideas or comments or questions on this really difficult situation. And it brings very much in the additional point of living donation, how to act with this. And if I just go on while you are maybe writing something, if a parent really want to give a living donation to a patient, but we see that it is not very likely to have success at the end for the patient, should we accept the wish of the parent? Have we to accept it? Or should we say, no, it's not possible. It's from medical point of view, not acceptable to do this. So when I had this discussion earlier, there was one who said, yeah, if there's a child who is drowning in a frozen sea and the father is jumping into the sea to put him out, to pick him up, would you stop him? And yeah, I mean, and this is even another situation, because in this situation, what he is doing, he well knows the risk of going into the frozen sea. But normal parent who goes into living donation liver transplant do not know what medical aspects will await him. And I think it's we have to protect him or her to do this. But this is my personal opinion. So what do we have so far here? Oh no, too big risk. Okay. Yeah, of course. How do we know that living expectancy is below 50? That's really a difficult question. I think there's no checklist where you can put on and at the end you calculate it. It's more what a multidisciplinary team with intensive care unit doctors, surgeons, ourselves, and so on, our experiences, let us guess. But of course, and we know that we all have had patients who thought will never do it, and they did it at the end. But yeah.
So why did you decide against waiting list against a deceased donor? Because this was a point I think colleagues are discussing. Why not to proceed with this deceased donor?
Yeah, so since the liver function was not enough worse to get the criteria for a primary non-function. So this was not a classical primary non-function. We didn't understand what was the problem with this organ, and it's, I think, multifactorial. It was the patient and the organ, but like I mentioned, we also realized or have been told that the other recipient also had very big problems with the organ. Okay, is it a syndromic BA? Yeah, there. It was no, it was not a syndromic BA. It was a classical BA, and there have been further children the parents need to take care. Actually, it was, I think, 4 or 5 further children.
There
And,
also there is another question in the chat which comes a little bit along with that one. It's what was the opinion of the father in terms of risk taking for his child? I don't know if you can see the chat.
Which one you
Because on the last comment, because some people quoted there's not enough space in the Mentier.
He if he would, or he wanted to do, yeah, he wanted to do. Okay.
Go on for your final decision.
And even
the option is go for donor living donor liver transplantation, no liver transplantation, or thinking about other options. You said criteria for high urgency were not fulfilled. However, we could ask for a special decision in this case by the ELITA board.
Yeah, but yeah, that's right. But still, we have to take into consideration that if we look at the criteria, the ET criteria, survival likelihood below 50% usually excludes you from liver transplant.
But it was your estimation, wasn't it?
Absolutely.
Mm-hmm. Okay, so dear colleagues, please proceed with your decision.
So and this is quite interesting or good because you are here to discuss, and maybe if I just already mentioned this, this is the first time the decision of the attendees is different to what we did. So we decided here, like you can see on the scale, that the cons are bigger than the pros for the patient, for the family, for the father. It looked like just putting the patient on more and more problems and pain and intensive care unit stays without a really good chance to survive this. And again, additionally, the risk for the living donor and the whole family with that. Because you have to imagine this really big compartment, the extremely gut edema, which really make it almost impossible to do a retransplant. Okay, so it's a very sad case, actually, absolutely, and we of course we really discussed it endless times, and it was a really difficult decision. But at the end, we decided to not do it.
Yeah, and it underlines that there's no right or wrong. I think it really depends on the specific clinical situation in these cases.
And there's maybe one question in the chat. I have a question. In my country, you cannot simultaneously be on the deceased donor list and on the living transplant list. So this is completely the opposite in Germany, or in, I would say, ET in general, in Eurotransplant. You have to be on the waiting list for deceased donor because the living donation is always a second option, and it's not allowed to have it as a first option, and you're just allowed to use it if you can show that the waiting list will not be able to save the patient. And for this, the patient has actively be on the waiting list. And of course, it's always good to have a diseased, to do not a living donation, to have a diseased organ, I would say, diseased donor organ. Yeah, but this is another topic.
Okay, let's continue with the next case. So first, it looks like a straightforward case. So it's an 8-year-old boy with new diagnosed Wilson disease and presented with acute and chronic liver failure. So there was no liver synthesis, and therefore colleagues in another center started treatment, but he did not improve on standard treatment, and that's why the other center decided to go for liver transplantation. And but the parents refused liver transplantation. They left the center nearly without comment and searched for, I call it, alternative treatment, and looked for another hospital offering non-standard medical treatment. However, this hospital contacted us and told us that they were not able to treat this patient because he's in need of a liver center and liver specific treatment, which was good. And then he presented to our center, and still really bad liver function with an INR of 3.6, high bilirubin, low transaminases, showing that there's really liver cirrhosis with no really hepatic function anymore. The boy had a mild hepatic encephalopathy, and still the family, parents, especially the father, I have to say, refused liver transplantation. And it was very hard discussions. We try really to explain him the risk of his son, the risk of acute deterioration if he not agrees with liver transplantation. But the father was very strict, and he refused to go for liver transplantation. So again, I'm curious for your comments. How shall we deal with the parents? What do you recommend us to do? What would you do in these situations? I think you can imagine similar situations in other disease and other clinical cases if parents refuse an important treatment, and the child was really in need of a liver transplant. So different situation, the other way around. We recommended liver transplantation, and the family, the father, did say no. So yes, you are asking about the concern of the father. The father, for him, it was difficult to see that his son is still stable, and he hoped that it would just take time. So he didn't really understand, or he had the idea that something else than school medicine might help to improve his son. That's why he looked for alternative treatment. He thought it would be some kind of unstable situation, and if the body is in the right move again, then liver will heal itself. That was the idea of the father. Otherwise, the father was very clear. He was not not orientated. He was very clear, but his hope was that the boy just needs time, or he needed time, and if he would have time, then the liver would recover by itself. So yes, we contacted the pediatricians, and it was like he came from the other part of Germany, from northern Germany, to South Germany because he was looking for something else. So that was really it's very difficult to explain. The mother was a little different. She really was open and did. She was also worried about her son, and that's why she was easier to contact. Yeah. Yes, so other family members, that was the one point, and also yes, the idea was, do we need help from outside, from court that a judge might decide for the family about the outcome. Yes, another opinion is a good point, but actually, as I mentioned, we were the second or the third center, and the other center recommended the same.
To maybe gives this crew indeed the patient was first at our center in Hanover, and this was the idea that he was not trusting us, and we said, okay, if you not trust us, we tried to explain you many times, please go for another very well experienced liver transplant center in Germany and get your second opinion and then rethink. And this was how it happened.
Yeah, so education is, I think education is very important. You are totally right. And to talk to the families and explain the increasing risk factors. I think in this situation that the father was really afraid about his son, and that's why he was not able to decide. But the outcome is even more funny, or more interesting. Yes, the mother, you're right. Sorry again for limiting the comments in Mentimeter. That was my fault. And yeah, you're right. The mother really was the clue because she was very helpful and to get for a final situation. Yeah, so and the only difficulty was that there was time pressure. So we were really worried that we would wait too long, and that's why we really have to discuss now. Shall we say, okay, it's the family's decision. The family can decide, and if they want not to go for transplant, we have to respect. Or should we say, in the interest of the boy who's just 8 years old, we should go for liver transplantation and ask the court to decide for this boy. So please give me your vote. Yeah. Yeah, the mother was in between when she first, I think, was also different in your center, knowing that the mother was with the father at first hand, and after the long discussions, the opinion of the mother changed over time.
Yeah.
Yeah, so thank you. I think yes, but it's difficult. So we asked our lawyer in this case, and so we didn't ask the family service. We didn't ask the court because the lawyer was enough for the father to really recognize that he has to understand the difficulty, and he has to consent in the child's interest. And finally, the interesting thing was that the father then said, okay, but I only agree if we do living donation liver transplantation. And so 1 week later, we performed living donation. And it's really the case, like Norman said, you have to be on the waiting list for liver transplantation. However, we discussed with the family, and it was also the worries of both mother and father that someone else might donate for their son, and so they agreed with living donation. The father was a perfect donor, so I think we in the balance of risk and chances, I think it was a good decision to go for a living donor liver transplantation. It was a liver transplantation without any complication, and he's now back again in North Germany, another city, and so they're doing very well. So without any further complications after liver transplant. So thank you for your input, and we go to the final case from Hanover.
Okay, so I try to make it fast. This is but it's again, of course, a tricky case. It's actually what you already see. It's a patient with Niemann-Pick C disease, and I mean, we all accept this is usually it's a clear contraindication for liver transplant, right? But how it happened, we took care for a 4-year-old patient here. He was transplanted in another liver center in Germany due to neonatal acute liver failure. And he was in a good general status at this age. For 4 years, he was followed up at our center because he had some arguments with the initial center, like it's always. And then, when he was 4 years, his sister was born, and again with acute neonatal hepatitis, not that severe than the brother. She was not in a really liver failure, but with a neonatal hepatitis, neonatal cholestasis, and in the diagnostic follow-up, we detected high elevated trioles. So NPC was suspicious, and we did the diagnosis. And at the end, she was diagnosed with Niemann-Pick C disease, and of course, retrospective genetic testing detected the same variants also in the brother. So knowledge of this would have led to a non-pediatric liver transplant in the neonatal period of this boy, and then most likely to death because he was really in acute liver failure. But not knowing the diagnosis led to liver transplant, and now, up to now, he's 12 years old, 12 years of life with mostly good quality of life. Last visit was with 12 years of age, like I mentioned, with a good, I mean, a kind of cognitive retardation. And he goes to school with some assistance. His walking is a little bit clumsily, but he can walk. He has no spastic, no ataxia, no seizure, no tremor. Rare events of swallow problems, like typical for these patients, but he can have normal meals with his parents, his family, no gaze palsy. So he's, I would say, in a quite good quality of life still with 12 years, which he would never have experienced maybe if his diagnosis was done earlier. So this is how it's sometimes diseases which are called contraindications for liver transplant, and in some cases liver transplant is accidentally, I would say accidentally done, and we see the patients do not that well like we thought they would do, and then everybody is thinking of maybe it's a good thing to do it or not. And this is also something which is also depending on organ shortage, and if the organ shortage is stronger, of course, you would not discuss in these cases like a mitochondriopathy or so. But if we not think on this and we think what we can do for this specific patient in this case, we would maybe think it's a good option. So what do you think? What does this case tell us? Does the case tell us maybe liver transplant for Niemann-Pick C disease is an option, or do we say it's just one case, it's just accidental, and still he has a progressive disease which will lead to death for sure before he, I don't know, maybe turn 30 years or something like this. For luck, we had not the situation for the sister because she recovered with supportive treatment from the liver, from the hepatitis, from the liver disease at the beginning. She's in a similar neurological status like the brother, also doing quite well for Niemann-Pick C disease. So what do you think? So far, it's not he and she has not severe lung disease. Yeah, I mean, she's not in need of liver transplant at the moment. To make this clear, I just wanted to just that due to the sister, the diagnosis came up retrospective. Yeah, of course. I mean, this is why it's usually a contraindication for pediatric liver transplants in Niemann-Pick disease, because the progressive neurological dysfunction. But in this case, it was not known at the point of liver transplant. Yeah, and this is the point. The phenotype is always heterogenic.
However, it might be difficult to decide firsthand if a child with acute liver disease and a picture of liver failure, should you do a transplant in these children, because you don't know how will be the outcome, the neurological outcome a few years later. I think it's difficult.
Absolutely, and I just wanted to show with this case that sometimes things are different than we expect. And yeah, I mean, the question, would the parents offer living donation? I mean, like I mentioned, for the sister, it's not a point right now. It's not necessary. Just in the brother, at this really neonatal period due to the more severe liver failure. And another point is that, in my opinion, if I say a disease has a contraindication, to put the patient on the transplant waiting list, on the disease donor list, I would say it's not fair to say, instead of, we could maybe do a living donation. In my opinion, if you say there's a contraindication, it's always for the living donation the same, because okay, you can say you do not use the organ from the waiting list, and it's a decision of the family if they want, even if it's limited outcome, do a living donation. But I think this is what we do at our center, and I also agree with, would not go for this to do then a living donation, because the family wants it. Okay. Anything else?
Let's go on.
Yeah.
Joe, would you transplant a child with Niemann-Pick disease in this situation?
Of course, it's difficult, because in the case it was not clear at the moment, and it was not done by knowledge of the disease. And retrospective, you never know how the patient behaves, and like mentioned, it's very heterogeneous who the disease develop. Yeah, it's really difficult to decide. And of course, it's sometimes in the acute liver failure, you not have the time to wait for the diagnostic, and also the diagnostic diagnostic marker tools develop over time. So yeah, this was the reason why it was done in the other center. I would say it was not a mistake at this situation in this moment, but the question is, what does it tell us? Okay.
I think it's an interesting final case. Probably there's no good answer. That's why I think it's
No.
now good to move on for your final remarks.
Yeah. Okay, so yeah, again, the scale for this patient. Yeah, knowing the disease, the scale would be like you can see with some higher weight on the con list, of course. But without knowing the disease and just seeing the outcome of the patient so far, you would go for the scale with the higher weight for the pro. side. So this is what the case was about, or what I wanted to just stimulate these thoughts in your head. Okay, so maybe we go for the final remarks. Yeah, one additional aspect we wanted to mention is who can help, and there are in almost every center ethical boards are available and can be a very helpful institution or tool to discuss the pros and cons, and to have an unbiased view on the situation from experts from different medical specialties sitting together and discussing this case. And of course, a multidisciplinary team, like I mentioned in the case 2, with the intensive care doctors, with the surgeons, and so on, is very much important. Yeah. So the conclusions are, like you have maybe recognized, there's not really a right and a wrong. Okay, next one. Decisions has to be made based on local circumstances and the situation of the patient and the family, and of course, like I mentioned, multidisciplinary team. And pediatricians should be the advocates for the children, of course, but also should protect the parents from unreasonable medical decisions, like a living donation, and really in a case where it's really not with a high chance of a good outcome, or medium chance at least. Organ shortage should have limited weight for the decisions, in my point of view. And living donation should not be done to protect the organ pool, in my point of view, or I would say in the point of view from our center, I can say, also Professor Baumann. And contraindications can change over time by growing experiences and by changes of donor availability. Okay, so I think that was everything we wanted to show and tell you. I hope you enjoyed. Thank you very much, Steffen, for this very also the time of preparing and so on. Thank you very much.
I think it was fun for all of us to discuss these cases. I hope you had also fun discussing the cases. And thank you for everyone who participated and everyone who could not participate. It was my fault, sorry, but however it worked for some of you and helpful. I think hopeful it's helpful also for you and your practice to see that it's not a right or wrong. It's a difficult decisions to make, and we really need to discuss these cases very careful with the whole team, and then we can get good answers, I think.
And also thank you very much, Benno, for inviting us and giving us the opportunity.
Of course. Thank you so much, both of you. You put a lot of effort, and there was so interesting cases. So many thanks again. And yeah, to all of the others, I hope to see you again in April. On the 23rd of April, we will have our next webinar about AI and machine learning. And I hope all of you have a nice start into the week. And yeah, see you next time. Bye-bye.
See you in Helsinki.
Yeah, yes. See you in Helsinki.
Of course. Bye.